once the interface is ready, like that
Okay, so I'm just going to be covering a little bit about diagnostic radiation and the facts and myths associated with that, and as a clinician, what your role is and how you can better answer your patients' questions when they come up with questions about CT or anything that comes up. Hopefully, this should summarize everything. Okay, so this is Wikipedia for everything. What is radiation? Now, generally, as we know it, it is used for ionizing radiation. There is lots of non-ionizing radiation around as well, which is irrelevant to us because it doesn't damage us. It doesn't do anything to the human body. But ionizing radiation has the capacity to damage cells. It causes ionization, and then it has sufficient energy basically to knock off the electrons of the atoms. And hence, it can lead to problems. But very few people know that radiation is everywhere. It's all around us. We've been living with us throughout our entire life. There's a background radiation throughout the world, about 2 to 3 millisieverts. And Bangalore is the same as the rest of the world. We aren't any different. Surprisingly, I found Kerala is much higher. So if you're planning on moving to Kerala, be aware that your background radiation is going to be much higher.
And why is that?
It's because of the natural geography of the location itself. They have much more radioactive material in the ground. So where does this background radiation come from? You'll be happy to know that 85% of this is actually from natural sources, and we are the culprits only in 15%. And this is the same more or less throughout the world, except in really very poor countries where there's very less diagnostic radiology happening, when there is very less contribution by the medical profession. So where does this radiation come from? 50% of it is from gases like radon and chloron. There's also about 12% in our food and drink, and there are cosmic rays. So all of this account for your background radiation. So has this changed over the years? Why is this becoming a topic now? It hasn't really changed over the years, but I'll come to that in a minute. You also get radiation to your flights. So if you have a long haul flight, say you're going from London to Tokyo, now that is going to be up to 3 chest x-rays for you in your flight. So there is also this additional factor that you need to be aware of. So, and as I said, it hasn't changed over the years. It was the same in BC as this cartoon depicts, and it's the same in AD. So over all these centuries, your background radiation hasn't changed at all. We're still being exposed to about 1.5 to 3 millisieverts as we were ages ago, as a caveman was, and nothing's changed. But why do we fear radiation? As I explained earlier, the radiation can damage the cell by damaging the DNA molecules itself, either directly by acting on it or through free radical formation. So the chain of events that happens is once you get exposed, you can have ionization, there are free radicals, molecular changes, so it can affect your DNA, RNA enzymes. You can have subcellular damage, so damage to the membranes, the nuclei, the chromosomes itself, and you can have damage at the cellular level. Now, one of this is by cell death, which is called as a deterministic effect. And for cell death to occur, you really have to have a massive dose. So this is what we see, like in Chernobyl or in the Japanese bombing. This is the deterministic effect. And this is also utilized in radiotherapy for oncology, for cancers. But in diagnostic radiology, this is what we are looking at. The cellular transformation. That is the effect that it has on DNA and RNA and enzymes. But before we go more into the details, I just want to touch a little bit on how radiation dose is calculated when a person undergoes a CT examination, for example. So for each and every organ, you have to estimate the absorbed dose. And this absorbed dose is actually the property of the type of radiation used itself and its tendency to cause ionization. Then every type of radiation has a different radiation weighing factor. So X-rays have different weighing factors, like things used for PET-CT, the radioactive materials, FDG, that has a different weighing factor. So that is then multiplied with the absorbed dose. And every organ and tissue has a different capacity to, has a different ability to absorb these doses itself. So the breast will be much more radiosensitive when you compare the liver, the bone marrow will be more sensitive, a child will be more sensitive than another. So all this is different, and this is done by lots of physicists spend a lot of time filling in models with saline and filling in packed cells, which is similar to your liver, similar to your spleen in consistency. And they spend lots of time to find out all this. Then each tissue has a different weighing factor, as I just explained. Then finally, you take a sum of all the organs that were in the radiation beam, and you arrive at the effective dose. And this is expressed in terms of MSV or millisieverts, and this is what we're looking for when you explain to patients how much dose. And this is the background radiation I was talking about as well, which is also explained in terms of millisieverts, which is 2 to 3 millisieverts. Okay. So how do we calculate the risk of radiation? Now this is something which is really difficult to measure. It is not something that you can do a control and a non-control group study saying, okay, I'm going to give you CT and I'm not going to give you CT and this is the dose you're going to get. Because nobody is going to agree for that. And it's not ethical for us to do it as well. So whatever we know has all been extrapolated from people who have been exposed to massive doses of radiation. So again, going back to Chernobyl and the Japanese, the Hiroshima bombings, the atomic bombings, that is from all the data at the moment we have has been extrapolated from that. So this model is actually called a linear no threshold model. So what this model assumes is if you have no radiation, you have no risk. Any radiation you have has a risk. Any extra radiation you get that equal amount of extra risk. Okay. So now that is a linear curve. But now there is a lot of debate among scientists if this is really a linear curve or if there is actually more to it than a linear relationship. That is something we have to wait and watch. There hasn't been any definite paper about this, about it not being linear. So we are continuing with this linear no threshold explanation for it. And also, what this theorizes that it is a probability of an effect occurring rather than the severity. So what it means is if you have one CT, your probability increases by so much. If you have 2 CTs, your probability of getting something increases by so much. It doesn't mean that you're going to have a more severe cancer or a more aggressive form of cancer because of getting 2 CTs instead of 1. So if we take this threshold, if you think about it in this linear no threshold way, people have come up with this number, which is 70 per million per 1 millisievert of exposure. What it means is if 1 million people were exposed to 1 millisievert, then 70 of them have a chance of getting fatal or non-fatal cancer or an hereditary. Okay? But people also say that there is no definite threshold for leukemia and solid tumors. And the latency period can be only a few years for leukemia, but up to 40 years for solid tumors. So in a person's lifetime, in an adult's lifetime, you may not even live long enough to express that extra risk that you've taken on by getting a CT. But children are much more at risk because they have a longer risk too, longer time to express this. The other effect which has been theorized is radiation damage to the gonads during reproductive period, produces mutation to the gametes and hence causes inherited diseases. But there has been no human study to prove this. This has all been on mice. So nothing has come out of this definitely. And even studies going back to look at people from the atomic bomb survivors, there has been no hereditary, statistically significant hereditary effects or cancers. So we can forget about this. So if you have young patients who are having their scan, including the genitals, then if people do come up with this, then hereditary effects are actually not known as of yet. Now going back to the deterministic effects, which is the ones which causes cell death, which is the dangerous one. Now this is where the malformations during pregnancy comes out, because looking at that, you can see that the period of organogenesis is between 3rd and 4th week. That is a really vulnerable window. So that can lead to death of the fetus or to really bad malformations. 8 to 15th week usually causes malformations of the forebrain. But this is looking at really high doses, so like 100 to 200 millisieverts, which is like 10 to 20 CT abdo-pelvises in one go. Someone having that much short, which we are not going to do in diagnostic radiology. So it's not really something that we need to worry about in what we do in diagnostic radiology. But if a fetus is irradiated, then it can increase the risk of cancer in later life. So coming to a safe dose. Now, this is very difficult to say like, okay, if you have this dose, then under this dose, it is safe for you. Beyond this, you're going to definitely get cancer. Because everything is cumulative and it depends upon each person's individuality, what are the risk factors they have, is it a child, is it an adult, everything. But what there is a dose for is occupational exposure. So people like me, or people like an interventional radiologist, or a radiographer who's in the field, who's in the room where an X-ray is being taken all the time. So for them, we have a threshold of 20 millisieverts per year considered to be a safe dose, which is what 2 CT apoptosis or 2 coronary CT angiograms. And this 20 millisieverts should be averaged over 5 years, with no more than 50 millisieverts in any single year. So basically what this is saying is, you can have little doses as long as it's averaged over 5 years, 20 millisieverts is okay. But you shouldn't go beyond it in one single exposure. You have to give your body a chance to repair itself before you go in and give it another dose. But there has also been papers which show that people in surgical ICU and trauma patients exceed this dose very easily because of the frequent imaging they have. So this is quite a wordy chart, I'm sorry about that, but just basically says what dose is given for each procedure, how many years or what time does it equate in terms of natural background radiation, and what is the risk of additional risk of cancer that you get with this. So if you were to go with the CT brain, which is the most commonest, you get about 2 millisieverts, which is a year's background radiation, or 8 months. And this is a very low risk. And very low risk is 1 in 100,000 to 1 in 10,000 extra. Okay? And if you go for a CT after pelvis, it is 10 millisieverts, which is 3 years of background radiation, which is low dose, a low risk, which is again 1 in 10,000 to 1 in 1,000. So all this risk is in addition to what you already have as a risk of being an adult, just a general population risk. So general population risk is of developing an invasive cancer is 1 in 3 for women and 1 in 2 for men, regardless of their imaging history. So what imaging is doing is just adding that 0.05 or 0.01% extra to what your natural risk is already. Depending on if that person is extremist in right front of you, he's probably never going to even, that risk is probably not even going to be for him in his lifetime. But this again does not take into consideration the individual risk factors. A smoker or someone with a family history is going to have much higher lifetime risk of developing a cancer than a non-smoker. And most of the cancers occur later in life. And the lifetime risk of dying from cancer is 25%. So 1 in 4 of us are going to have cancer at some point. Internet is amazing. I found this thing on Google, which is you go into this, you put in what CT scan you have, put your age and your sex, and how many exams. It gives you a dose. It gives you how much extra risk, what is your baseline risk, and what increased risk you have because of this. And you can print this out and add this to your report as well. So for people who are very pedantic about wanting to know how much extra radiation I've got, this is a really good website. I think it is also, and the doses are about as accurate as I could find as well. They aren't any different to what I found in the literature. But this is all about adults. What about children? Children are much, much more sensitive to radiation than adults. One, because they have dividing cells, so they're much more prone to damage. They have a longer life expectancy than adults. And sometimes they may receive a higher radiation dose than necessary if we don't fine-tune the CT machine as we should for the children itself. So there's been a recent study in Lancet looking at children who've had scans at less than 10 years of age, and they've looked only at brain scans when they've been less than 10 years of age and how many scans they have. So they've looked at the cumulative dose and the risk, they found a linear relationship with increase in number of CTs. So say a child had cumulative dose of 50 to 60 milligray, which is the same as millisieverts. There's 3 CT heads. They have a 3-fold increase of brain tumor. So it's a direct linear relationship. And if they have the same dose to a bone marrow, which is 5 to 10 CT heads, there's a 3-fold increase in risk of leukemia. So in children, this linear no threshold relationship still holds good. And the comparison group consists of children who had less than 5 milligrays. So 1 CT compared to 3 CTs, and then the risk definitely increases. But if you look at in terms of a population, it doesn't amount to much more cancers. It is basically 1 excess cancer of leukemia, or 1 excess leukemia, or 1 excess brain tumor per 10,000 head CT scans if you increase the number of CTs. So again, it is unfortunate for that individual child, but if you look at the whole population as such, it is not that big a change in number. There is the Image Gently campaign, which has been going on for several years now, and this is mainly aimed for children, and it has a tagline that we have to look after the children and we have to help reduce the radiation to children. So every CT scanner as such has inbuilt protocols which is just for children, which is reduce the dose as much as possible with the best image quality you can get and what you can get away with. And this is been going on for several years and going on in several countries, and we follow this the rules set by the Image Gently campaign as well. So we've discussed this already, and this is their tagline. They have lovely handouts to be given, and this is from one of the handouts. So in case you have parents asking, this is a nice way of explaining to them that you have your natural background radiation. If you have a long flight, this is what you get. And for a chest X-ray in a child, you get a little bit lesser dose than an adult does. So the background radiation is equal to 1 day. If you have a head CT, it's for a child, you have 8 months of background radiation. For an abdominal CT, you have 20 months of background radiation. This is with the reduced doses that we use for pediatrics. So what can we do here, you as clinicians especially, to reduce the dose for your patients? One is to justify the examination. Is this examination approved as justified for this condition? Has this patient had any recent scans elsewhere? Is there any possibility you can get hold of them? Is a repeat scan really necessary? And optimization. Have I chosen the correct examination for this particular patient, for the diagnosis that you want? What we do from the radiological department, we use the ALARA principle, which is as low as reasonably practicable. And I have personally seen this, that we override the automatic detectors in our CT to bring down the dose. Because if you leave it as automatic, the CT scanner wants to get the best image and it will increase all the doses. So we manually do it. We have used bismuth breast shields for all women, which reduces the dose to the breast by 40 to 60%. We have separate guidelines for pediatric age group, which is set by the Image Gently campaign. For any child having periphery chest X-rays, they get lead shielding. And all our CT technicians are trained using ACR image wisely training program. And we use the protocols to minimize radiation dose. And we also monitor the dose on all our patients. So whoever comes in, we have a logbook. We write their name, age, and how much dose they've had at the end of the procedure. This is the protocol for children, and the children is always done according to their weight. So that is the weight in terms of kilograms, and these are the different parameters that they go into to get the optimum image quality and less dose for pediatric age group. Okay, so this is just something that we've proposed that you can go through when you are referring anyone for a CT. Most of you are aware of this already. We've just made it into a tabular form. So if you have a patient you want to refer for a CT brain, if it is a trauma brain, a non-contrast CT is enough, it's sufficient. If it's normal, that's fine, you can go home. If it's for a headache, and it's a chronic headache, you can have a non-contrast CT, or you can even go for an MRI. There's no reason, if it's a long-standing headache patient who's had it for 2 months, it's not going to make any difference for her to have to wait 1 more day to get an MRI. However, if you go ahead with a non-contrast CT, and if it is normal, and you don't think clinically there's anything to worry about, you can discharge the patient, no more imaging, or you can go for an MRI if you're still clinically convinced that there's something going on which the CT hasn't picked up. On a non-contrast CT, you see an abnormal mass, then you can go ahead with a contrast CT or with an MRI again. So you can basically stop most of your brain images there unless you find an abnormality or you're clinically convinced that there is much more going on here. Because CT has its limits. You're not going to see small lesions in CT. The posterior fossa structures are not well visualized in CT, which you have to be aware of. So the next is abdo-pelvis. And this is something I used to follow where I worked before. And it's basically, if a person comes with, if you're carrying renal calculus, which I see is really common here, everyone seems to have renal calculus. And if they are positive for dipstick hematuria, then they go for a non-contrast CT, and there is another specific CT called a CT-KUB, which is almost 1/3 the dose of a normal CT abdo-pelvis. And that will pick up a stone. That's just a stone for a coffee. So, and you'll pick up the stone, you'll pick up the hydronephrosis, that's fine, that's all you need for this. They can go. If they don't have hematuria and you're suspecting appendicitis, cholecystitis, or someone who drinks a lot, has got cirrhosis, and if it's a child or a woman or even a man, young person with a normal BMI in adults, that's important, you refer them for an ultrasound first. Ultrasound is brilliant for cholecystitis and cirrhosis. You get much better imaging of the liver and the gallbladder than you would from CT. CT is not good for that. Appendicitis in a child, you can pick up most of the time. But if you cannot pick up and you're clinically suspicious of it, then there is no reason why you can't go ahead with the CT abdo-pelvis. But most of these things can be answered by ultrasound, especially cholecystitis.
Oh, sorry to interrupt you,
Yeah.
but there was a patient with ultrasound showing it as there is no appendicitis,
Yeah.
but he had a severe symptom.
Okay.
Clinically, we did a CT scan. It was showing a very huge appendix,
Okay.
and we know that. I mean, what I can we have learned is ultrasound detecting an appendicitis on an ultrasound takes a very severe expertise, and it has to be done by a very senior radiologist or very experienced radiologist, unless they know. Actually, it was I know the patient name also. It's a very huge one. It was about 13 millimeters, and he.
Yes, I agree with that point entirely, that it has to be done by someone who's skilled and who's used to looking at appendices as well. But that's why I put in the caveat, if ultrasound is negative, but there's still a high clinical suspicion, then go ahead with CT. There's no harm in that. But you can use it as a rule, as a thing to exclude these things as well. If you think there's a child and you think it's most likely mesenteric adenitis, which is also another common thing that a lot of kids come with, and the ultrasound is negative, and you're not thinking, and there is no leukocytosis, and you think, okay, this clinically doesn't look at appendicitis, you can leave it for a day, and if you're able to convince the patient, and if he's getting better with that, you can let it be. You have avoided a whole CT abdo-pelvis, which is a lot of radiation for a child. And children, especially, ultrasound is much more easier because most of them are slim, and you can visualize the organs very nicely with ultrasound. But again, it depends on your clinical suspicion. If you think, okay, this patient is an extremist, ultrasound has come back negative, I need to know what's happening, go ahead with CT straight. And ultrasound also should remember that even if you have a little bit of free fluid, that is pathological. Because what happens I don't know this particular case, but if the appendix is very large, it can be mistaken to be small bowel, which is a mistake that can happen. Yeah. So that is another thing that we have to think of.
They have shown the scan image also, the right pelvic, nothing, it was just blank. I couldn't make out. It was fully blank. There is no free fluid or whatever it was there, and even the left iliacus was normal. They had put the image also, so. We thought because he had severe pain,
Yeah.
so
That would be the right thing to do in that case. Okay,
no,
so
but
just going-
but my point is why don't we because it might not pick up, the ultrasound may not, or if there is a chance that we might miss out, and
Yeah.
we might say it is negative, can go, and it ruptures, then it will be a problem, right? So would it be not
But-
right to?
It depends on. Yeah, sorry.
No, Siddharth, you just said that the patient was in a lot of pain, right?
No,
So
after
clinic
clinic
is
after
honestly-
a lot of the McBurney's point, too much pressing, I examined for him for 20 minutes because it was normal, ultrasound was normal. So just I asked him whether you have pain, and he said, okay, looks like appendix, do a scan just to rule out if I had 2-3 days. Then he got it done and it was positive. So,
So was the
then
CT done on the same day as ultrasound or later?
I think on the same day itself,
Okay.
same day. He
Yeah.
had went outside. We didn't get an appointment here.
Yeah.
He went outside, got the ultrasound done, and came back. And then he still had pain. Like, what to do? He's taking already antibiotics, and his counts were also not so high.
Okay.
So I think
Yeah, I mean there are cases that I don't
if
say
there's
that
chance of
ultrasound-
missing
yeah,
it,
these cases like this can happen, but most of the time it's very obvious.
Especially
no, I haven't seen. Unless there is a very experienced and the machine is too good, I don't think the ultrasound, I mean appendix can be picked out easily.
I think our ultrasound machine is reasonably okay. I've got it, have a look
I
at it.
don't know.
And it's reasonably good. And yeah, I mean, there will be cases like that. I cannot deny
Okay.
that, it's never going to happen. Ultrasound is going to pick up 100%. They have to
Okay.
look into figures about that as well. And ultrasound is ultimately operator dependent.
Hmm.
So it depends on how much experience a person has in looking for the appendix as such, and if they use the right amount, right probes and everything.
But as Siddharth said, that this is he's right, because the most of the studies now they say that CT scan is good for stone protocol, stone protocol, and for appendicitis. And ultrasound is much better for right upper quadrant. Like if you have elevated LFT,
Cholecystitis.
usually for liver problems, ultrasound is much better.
But for a child,
For a
the
child.
for a
For a
child,
child,
yeah,
for a
the
child,
radiation
child,
exposure
yeah,
is
I'm
so
not-
Of child
yeah, I'm
estimate.
not- I'm not-
That's why I have added them.
Yeah,
right?
yeah.
So,
Yeah, no, I totally agree.
first, there's no
But
harm
you
in
use
first
it
doing
as ultrasound,
ultrasound and then proceeding
See, for
to a
adults,
CT.
it's the
For adults, it's
No, for kids, I totally agree. And I've had kids when I worked in the ER when the ultrasound was negative, but then you go back clinical and clinically he was still, so we did a CT and he did have an appendicitis. But you want to avoid CT scans for kids as much as
Right,
possible.
That is my whole point of this
No,
thing of the
the
chart.
kids
Yeah.
we can leave it, but which is superior? Because it gives a straightforward,
For adults,
quick diagnosis.
yeah.
Than nowadays everybody is on the toes. Everybody wants to know the diagnosis quickly. So that prompts us to
That's the sad part.
So
yeah.
there's
but
nothing
adult
like
CT
you don't have, don't have. So CT says it
In
doesn't have.
adults, I agree that overall CT is superior. There's no doubt about it. But it
Okay.
is the risk that how much you want to give the risk to the child. If there is a patient who is like worried about radiation and you think it's appendicitis, there's no harm in doing the ultrasound first. It also helps them have a bit more like, okay, I'm not having a CT yet. You're doing the ultrasound first. And then you can go ahead, you think, no, this is not right, and the ultrasound may have missed it, let's do a CT. That's more than appropriate to do it. And also, I mean, adults, I don't
Theoretically
think
it
it's
looks
not a
good,
problem.
but practically it's wait for the ultrasound report. I have to call the radiologist. Is it done? Then bladder is not full. Is it done? Then no. So
That-
practically
that-
it's
that-
that point is.
That's our
bit-
job as a doctor.
Yeah.
So once okay, I've ordered for the CT. Okay, report will come. I have to be here. So practically it might look CT might be better, I suppose. But theoretically,
Yeah,
ultrasound
but I mean,
should.
if, like
be
I have seen, if you have a young woman who's already not even started her family and you're sending her through a CT,
Yeah, for them I think.
see,
Yeah.
those
Yeah.
things you have to think about.
Sure.
Overall, it is your responsibility because you are
Yeah.
referring here,
Yeah.
isn't it? So you have
Women,
to justify
children will
by
give
yourself. Yeah. So yeah, we've been through this limb now, and the next one, like any other pathology, you think like we did pancreatitis last time. So you think there's pancreatitis or anything else, a cancer, someone losing weight. All of them taken good directly first. So our next one is a chest limb. So anyone thinking of an interstitial lung disease, a HRCT is better. Not only looking for lungs, it is actually much lesser dose as well because it's just a sampling CT. It's not really a whole volume CT. If you think of anything else, I would always suggest for anything chest, do a chest X-ray first. And if that is normal, then you can think of, oh, you're still thinking PE. Normally in my whole practice limb, a D-dimer and all the criteria would be involved in this, but I don't think we actually do that here. It's not possible, I suppose, to do it as well, so you can go ahead with the CTPA. And any other pathology you think, a mass or pulmonary hypertension, whatever, then you go ahead with the CT with IV contrast. So this is just a rough thing of what we could do, I suppose, as opposed to, I think most of this we are already following, but if you are stuck at any point, it's a good referral thing that you can do this. and
So
go
you're trying to
with
say
that.
that except for the interstitial lung diseases, all need contrast.
No, not necessarily. They don't need IV contrast. Okay, I have to put a plus minus in there. Sorry. All of them don't need. If it's a nodule follow-up, or if you just think there is something, they don't need IV contrast. They just need to, just need a measurement for that, and that's. Yeah, this was the main thing, which I'm glad we discussed, because this is what I was also thinking. For these things, we don't really need a CT, but clinically, that's what matters. You need to identify those people who will benefit from a CT and go ahead with that when you think is right. Just a few things about MRI. There's no radiation involved, so it's brilliant. You don't have to answer any patients. That is excellent for soft tissue. So you have MSK, anyone with a dodgy knee, a dodgy back, foot pain, anything, they can all go for MRs. Brains also, if they've got a chronic headache, go for MR. There's no reason they need a CT unless it's so severe that they want it straight away, then you get it done. Brains are the least radiation dose you can give to a patient, so you can be a bit relaxed about it. Again, evaluation of the biliary tree, so an MRCP and things, you can go with MRI. The only limitations of MRI is the scan times are long, so it can take up to half an hour to 45 minutes. It's claustrophobic. People may need things across the face. They don't like it. It's noisy. Children don't like it. And patients need to be able to lie still and hold their breath if it's an abdominal examination. Children, really small babies, you can probably get away with a feed and swaddle them and put them in the MR scanner. But a bit older ones will probably need sedation. And I realized it is quite a bit more expensive, at least locally, for a CT to MR. And this is for MR of any part of the body. This is the starting price, is what I understand. But anything that has been going on for a while, like a chronic thing, which can be resolved by MRI, you can go ahead with MRI. So in conclusion, my whole point is medical radiation has great benefits and we should not fear it, especially used in the right situation. The dose and risk depends upon good methodology, good quality control, which we try our best to do. And the indications and decisions should reflect the possibility of using non-ionizing radiation. So do think, is MRI or ultrasound better? Can we get away with this first and then go on for a CT? And repetition of examination should be avoided. If the patient is going to some other clinic or he's coming from some other clinic where he's already had a scan, try and get hold of that and get that reviewed rather than repeating the scan here. So these are some papers if anyone's interested, and this is the summary of the whole.
Questions?
Supposing you do a CT KUB and then you want to do a follow-up,
Okay.
is it advisable or what is your
Follow-up in the sense, do you want to know if the stone has reduced in size
or
or
disappeared,
sorry?
or if it's disappeared?
It depends on where the situation of the stone was initially. If the initial one was just an obstructing tiny calculus at the VUJ, then all you need to do is an ultrasound again to see if there's hydronephrosis or not. If the hydronephrosis has resolved, most likely the stone has passed from the VUJ and you can look at the bladder, see if it's still in the bladder or not. If it is one of these large staghorn type calculi, then I know where we would practice before, they would have a CT KUB. At the same time, they would have a plain film as well to see if the stone is visible on plain film. Then they would follow it up with plain film. So that is another way that you can do, depending on the size of stones and what your
Ovarian cyst, what would you recommend?
ultrasound.
Ultrasound. Even if you suspect it is malignant or
Well, once it is
cancer.
proven to be malignant, you can go ahead for a CT just to make sure that there is no peritoneal seeding, no extra peritoneal spread. To look for spread, then you would go ahead with a CT. But initially, if on a CT you've picked up an ovarian cyst, ultrasound, and especially a transvaginal ultrasound if it is a smaller cyst, is the best because it will evaluate the septate, the nodularity, the peptide projections. All that you need will be on an ultrasound much better identified, or an MRI rather than a CT.
Thank you.
neuroma, you need an MRIM, which is high resolution MRIMs, and they are the best and the only thing I would recommend for acoustic neuroma. Unless the patient has a pacemaker and cannot go in an MRI scanner, there's no reason he can't have it.
Is there a limit to the number of CTs a kid can have in a year or in a lifetime?
In a year, in a lifetime, it's very hard to project over the years. But if you look at that Lancet paper which has come out just recently this year, it says that there's a linear relationship. So I would limit it to as much as possible, at least not try to repeat it within the same year. Give chance for recovery, then maybe the next year, and then do it. But there's no concrete evidence on that as such that I could find, but I would think that that would possibly be the best solution.
So just like pacemaker for MRI contraindication, even the knee replacement patients, we have to have a list of people that.
Knee replacement isn't, unless, if it's an old knee replacement, it doesn't matter.
No, but the
And
newer
it depends.
ones.
Sorry?
Aren't the newer ones?
Newer ones are the titanium ones, so that's fine.
Okay, that's
Most
fine.
of them are fine.
Okay,
And most of them will have a manufacturer thing, or if you speak to the person,
I could.
the titanium ones are fine.
Fine,
There's
okay.
no problem with
But
titanium ones.
which ones are not fine?
The really old ones where they use proper metal. But even then, depends on where it is in the body. If you're scanning the brain and
Yes.
it's got a knee replacement,
Okay.
which has been there for several years, it hardly causes any problem. And
Talking to a
not
cardiologist, he said that most of the stents are now, you can do an
Yeah.
MRI. He says prior to 2007, those stents were not very, they were using metal, but now all the stents.
The most
you
of
can
them
do
are
it in
titanium
MRI.
and they've been shown to be MR safe. So you should be alright, but you can always, the difficulty is because, I don't know, you probably don't get the patient notes here, because you can always ask the manufacturer, is this MR safe or not, and that's easy to find out. But anything that has been there for a long time, like a hip replacement which has been there for yonks of years, it's not a problem at all going into an MR scan.
If you have a coronary CT and it's negative,
Sorry?
if you have a coronary CT
Okay.
and it's negative,
Yeah.
and then they want to repeat it, let's say no real history or anything.
Okay.
Is it safe within 5 years, or is there any such thing? I mean, I normally tell them don't do it for 10 years. But I don't know if that's scientific.
If you look up at the yearly, like the whole year dose, like you can, the occupational exposure that we speak of is 20 millisieverts averaged over 5 years. So one CTA is approximately 10 millisieverts. So 5 years is okay, or averaged over 5 years, averaged over 3 or 4 years is also fine. But obviously again it goes on your clinical thing. Does he really need it or not?
Yeah.
It all depends on that.
There's an interesting case. 6 months back, 40-year-old gentleman had a CT angiogram which was negative. 2 days back, he had an inferior wall MI. He had to be stented to the right coronary. So we can't say that if your CT scan is normal, that nothing is going to happen to you.
Because the physiology
But that's-
says
yeah.
there is a plaque rupture.
You can't, and you also it's more depending upon the calcification. That is what we see of it.
Factors.
So I'm not really an expert on cardiac CT, so I won't go much more into detail about that. But
No, we use it for screening, and we say if everything is normal, you don't have to worry, provided your calcium score is
but
normal.
I think from what I understand is the CTA is mainly dependent a lot on the calcified plaques. The non-calcified plaques are not reliably picked up. So that is one caveat which is probably also there in the report from a few reports that I have read. So that is one thing that you have to bear in mind. That this is calcium scoring, that is calcified plaques. You can get soft plaques, which can then go on and get embolized. You can get them.
I think thank you very much.
So, Dr. Vijaya Sarathy was supposed to give this talk, and he had sent us the presentation, and he couldn't make it. So, I thought I'll just present that to you. I tried to blend his presentation with some of Siddharth's slides and my slides and give you. Now, vitamin D is the magic word. You go to doctors for dizziness, you go to doctors for body aches, you go to doctors for weight loss, you go to doctors for asthenia. We'll check your vitamin D levels. I mean, patients everywhere, people are becoming aware of vitamin D level, deficiency of vitamin D, and what it's doing to our bodies. So I've just tried to make a summary of the physiology, the effects. There are so many of them that I couldn't bring everything out, but relevant to internal medicine and as a physician's relevance, I've tried to bring out a few things. So if I haven't brought out the entire body's organ systems that are affected by vitamin D, excuse me, because I just had to choose few of them. So, so for vitamin D, the ultraviolet B rays from the sun and work on the skin cells, and the vitamin D3 in the skin is at that time activated. Then it is hydroxylated in the liver. It is second hydroxylation in the kidney, which is the active form, and then that acts on the bone, the intestines, calcium absorption, and the parathyroid secretion. So that's how it really works in the body. Now this was something that I was just showing the main points, which is in the skin, the 7-dehydrocholesterol. So that is what is the precursor on which the UVB radiation works, and that converts it to the pre-vitamin D3. So remember that fat in our skin cells is very important for us to absorb the vitamin D or convert the vitamin D to the pre-vitamin D3 from the dehydrocolesterols, and that becomes cholecalciferol. That in the hepatocytes becomes hydroxylated to the first form, which is calcidiol, which in the kidney becomes, the calcidiol is worked by the parathyroid hormone, and it becomes the calcitriol, which is the active form. And that active form, which is the 125 hydroxylated vitamin D3, actually works in the kidney for resorption of calcium, in bone for the growth, development, remodeling, and in the gut for the uptake of the ingested calcium and phosphorus, immune cells, pancreatic beta cells for insulin secretion synthesis, parathyroid gland, and the skin. So I just wanted to make sure that people know the various forms of Ds, because there's a lot of confusion in blood tests. What are we actually measuring? And I've heard all kinds of things. So I just want to let you know that there are 5 different. There are 5 different vitamin Ds, and just remember that the only one to remember which works for adults mostly is vitamin D3. Okay, so there is D2, which is being talked about. So the injectable forms of vitamin D, they're not D2, but they're the forms of vitamin D3 which are actually not very usable by the target organs. So there is a strong discouragement from the injectable use of vitamin D for acute D3s. The oral forms work very well too in higher doses. Just to give you a little bit on the skin absorption of, I really believe this was a very important point, and there is a study, there have been studies which say that melanin inhibits the absorption of vitamin D. But now in the last few months, more and more studies are coming out, and they're saying, because the reason it came up was in African patients, the vitamin D levels were low, and so was the Indian subcontinent, but we had enough sunshine. And we thought that there was something in the skin, and melanin does have a role, but not very significant as most studies are coming out. And they're saying that even with darker skins, you will absorb enough vitamin D. And what they're saying is that the darker skin people, like in Africa, where the vitamin D levels were very low, is because of the kidney issues related. Parathyroid hormone levels were higher in them compared to the Caucasian counterparts, and as a result of that, the vitamin D levels were low. So there are more studies coming out of that. So I wanted to bring this lab test out, and I called Dr. Jayaraman from Anand Labs, and I just wanted to get him a summary of what meant by vitamin D. So what we are checking right now is 25. So when people write for vitamin D, please write vitamin D level, because at the current time we are doing radioimmunoassay through antibody method, and we are actually assessing vitamin D, which is a combination of the D2 and the D3. Now in adults, D2 is only 5% and D3 is 95%. So there was this whole issue that if we are doing a combination of D2 and D3, what should be the reference ranges? Should it be the 30-20-10 that we are doing? And Dr. Jayaraman said that just follow the 30-20-10, because
D2 is only about 5% of that. And this is a much cheaper method, but much less insensitive. In the world, they are using the mass spectrometry method, which measures D2 and D3 separately, and Anand has got a new machine for that. They charge a little extra, but in which there will be a separate reporting of D2 and a separate reporting of D3. I think we are already asking them to do that for us. 125 hydroxylated D3 is not measured only for very specific conditions where you have parathyroid, kidney, cystic fibrosis, specific conditions in which the 125 hydroxylated D3 might be related if asked. Not much of the calcium I wanted to bring in, but Dr. Sarathy had a couple of slides which basically just tells you that the body has its own hemostasis of calcium, and which is this extracellular fluid calcium of 900 milligram, which should be maintained by intake, reabsorptions, and bone movement and soft tissue movement. So the daily requirement for that should be at least 1 gram per day of calcium intake. This was interesting and very important, I felt. And so in this, how does calcium, suppose there is a stimulus of rising blood calcium levels. The thyroid gland at that point releases calcitonin. As calcitonin, if you remember, is used in women as a nasal spray for osteoporosis, it helps to stimulate the deposition of calcium in bones, which is required for osteoporotic people. And it also causes the kidney to lose calcium. And as a result of it, the blood calcium levels become less, comes to a set point, and homeostasis is achieved. Another way, when the parathyroid gland sense that is falling blood calcium level, high parathyroid hormone is released, which causes bone release of calcium, causes reuptake of calcium by the kidney, and it also, the parathyroid hormone also works in the kidney for the 125 hydroxylation of D3, which goes to the intestine, takes calcium, reuptake of calcium. So there are 3 ways calcium goes to the blood: through the intestinal reabsorption, to the kidney, and through the bone, and as a result of it, the blood calcium level rises. Okay, basically this was a pre-made slide, but what I got out of it is to remember that there are reportings in India from north to south where nanogram per ml and nanomole per ml is reported. So there are 2 different levels. Please don't get confused. There's quite a lot of variation, and I've had reports come to me where they were given okay with nanomoles, and the nanomole reporting is much higher than the nanogram per ml reporting. So just make sure that you guys are watching which units this is basically reported in. And less than 20 is deficiency. 20 to 30 is insufficiency. Let's keep it 30. And 30 to about 80 is actually sufficiency. And people from 54 to 90 in normal and sunny countries, I mean, let's not even take that into account because India is very sunny and Africa is very sunny, but the levels are very low for that. And more than 100, of course, is an excess. And more than 150 might cause intoxication. Very, very rare. Okay, these are numbers from India. 90 deficiency of vitamin D, 94% in urban Indians, 70% in rural. I don't know why the difference, because probably we have so much of the pollution. And basically too much use of sunscreen, clothing coverage, increased age, inadequate diet, obesity might be some factors which contribute. So this was something that Dr. Sarathy put in there, and I just left it. There's a study from high altitude Bangalore study which showed was done on 150 males and 606 females, and males age was 50 plus minus 1 and females was 51 around, and all had vitamin D. Every single person of those in that study had a level less than 20 nanograms per ml. That's how it's prevalent. And the levels in males were 12, around 12, and in female around 30. And this was another, and Dr. Sarathy was also quoted in that. And this this was another study in the western part of India. And age group was 25-30. The numbers were 1137. 70% of them had less than 20 nanogram. And low dietary calcium intake was one of the reasons. And high dietary phytates, which is the fibers, phytate to calcium ratio in the diet was high, which actually also bound the calcium and took it out of the gut. Now I was interested in this, but rickets, osteomalacia, osteoporosis, kidney disease, hepatic failure, cystic fibrosis. These are all these conditions which can have. The only important ones I wanted to for you, which you might miss, is the anti-seizure medicine, corticoids, AIDS medication, ketoconazole, and cholesterol. These are very important things, I thought. Pregnant and lactating women require more. What it causes? Wow, these are not fitting in there, but anyway. Depression. It's a very strong. More and more studies are coming out of relation of hypovitaminosis D with depression. Infections, a lot of influenza A, asthma, tuberculosis, wheezing diseases from vitamin D. So watch out if your patients are chronic asthmatics. Make sure you do a vitamin D level. I will come on further details with diabetes and vascular diseases, but muscle weakness, osteoporosis, obviously rickets, malabsorption syndromes, abdominal, lot of GI diseases, medications like glucocorticoids, etc. Sunscreen, having melanin, latitude, altitude, winter weather. These are all the reasons why your absorption is less. Now they're coming out with a lot of autoimmune and cancer-related issues with vitamin D deficiency. So it's every single thing. Basically, there is a faulty mitochondrial expression of a particular glycoprotein, which causes all the cells in different organs to be affected by it. This was some X-rays that he had put in rickets, and you can't see them clearly, but osteomalacia, you see that. Then bone density, osteoporosis, osteopenia. So I wanted to bring it out. Diabetes is very close to my heart. It's, vitamin D has been shown to be associated with diabetes and vitamin D deficiency. Type 1 and type 2 both. It affects the beta cells, so there's decreased insulin secretion, and also at the muscle level and there's a decreased insulin sensitivity, so there's more resistance. And there is definite systemic inflammation with decreased vitamin D levels, high CRP levels, which will affect both diabetes and vascular diseases. So again, we talk about the systemic inflammation that has been linked with insulin resistance and development of diabetes. So there are cytokines elevated, and they cause beta cell dysfunction and their death. Similarly, they improve insulin sensitivity, promote beta cell survival by directly modulating the generation effects of cytokines. It is also associated with increased circulating CRP, let's remember, and they are inflammatory vascular damaging agents. So vitamin D status in diabetes again, and it's been found that people who have vitamin D status which is low, or which have a normal vitamin D status, are in the higher tertile of vitamin D status, have a 40% lower incidence of type 2 diabetes. These are really related and compared to in these studies. Low serum concentration of vitamin D, impaired glucose tolerance. High vitamin D status provides protection against type 2. It constantly repeats and says the same thing. Metabolic syndrome. So there were studies which showed that taking vitamin D every day in a dose of 4,000 international units helps to improve insulin resistance in women who have PCOD or insulin resistance or obesity. And was most improved, some of the studies showed the levels more than 80 actually correlated the best. But I again said that in India, the guidelines in the world guidelines is still 30 to 80. So I wouldn't say go for more than 80 levels. Let's keep it below 80, because then the incidence of kidney stones and the other side effects of higher hypercalcemia from vitamin D absorption might be there. Again, so cardiovascular diseases. Okay. So there are few ways. Of course, the insulin resistance, beta cell, then the increased parathyroid hormone, which is known to cause inflammation, inflammatory atherosclerosis, and cardiovascular events. Arterial resistance, hypertension, and hypertrophy also increases with low vitamin D levels. Again, inflammatory cytokines contribute to congestive heart failure, remember. So again, vitamin D, low vitamin D levels, high cytokines, high inflammatory CRP indicators, and CHF in cardiovascular disease. There are studies that are now showing that vitamin D decreases LDL-C levels. And if you look at, they have come, this is the first product that's come out which does have atorvastatin with folic acid, B6 and D3, which is that, what is that called? Ultra lipifol, which is, so they're going to make more and more of these combinations where they might be adding D3 with anti-lipid, hopefully, and that's going to help the LDL-C levels more. Infectious disease. Again, vitamin D regulates the production of antimicrobial peptides, which are basically, this is beta defensin, which inhibit the function of viruses and bacteria, and as a result of it, that helps in influenza and prevention of respiratory infections. And let's see, vitamin D levels of more than 38 was associated with a twofold decrease in the risk of developing acute viral infections, as I said, and the burden of illness decreases. There's huge studies being done on skin diseases and dermatology with vitamin D deficiencies. And again, they feel that beta defensin and cathelicidin are the main antimicrobial peptides which prevent skin infections and dermatitis, and even atopic dermatitis, a lot to do with that. Tuberculosis, I was reading about tuberculosis, and there's some, in the old history of treatment of vitamin D, of tuberculosis, 30-40 years back, they were actually at that time giving vitamin D along with the treatment for whatever reason. I didn't go into the depth of it. So tuberculosis somewhere has a deep association between the progression of disease and tuberculosis with vitamin D. What to do? With dosing, do you want to give high doses? Do you want to give a steady daily dose? Who requires, before giving the doses, remember, obesity, people with malabsorption, and drugs, as I said, anti-seizure medicines, ketoconazoles, HIV medications, which we don't use that much, but there are the list of medications which increases the vitamin D metabolisms. So you have to give higher doses. According to the World Endocrinology Society, weekly therapy of 50,000, which we here use 60,000, do it for 6 to 8 weeks in adults, 8 weeks, and then you need to do a daily dosing. 4,000 K every day is advisable for adults. Sonal, what do you think about children?
Yeah, usually what I have read is around anywhere the daily requirement is less than a year, they say around between 400 to 800, and above a year it's 1,000.
But if it's a deficient patient, you give it for about 6 to 8 weeks high dose, pulse, weekly, oral dose, and then if you want to do a daily therapy and you realize that by giving 600 to 800 they continue to fall down rapidly, you might want to maintain on 2,000 for children.
Right,
It has 4,000.
Yeah.
So there were these are some of these studies that say that weekly 60,000 wouldn't support in Asian India. So there's a study coming out of AIMS which said that even by giving 8 weeks of 60,000, we still could not maintain sufficient vitamin D levels. What they really say is that daily up to 6,000 or up to 10,000, 4,000 will build up over time more than daily. But I'll tell you, the world guidelines are still that if the patient is less than 20, you have to give weekly for 8 weeks initially with 60, and then go down to daily. Okay. So they again say that if you give for much longer time weekly treatments, then there's a high chance that you can get hypercalcemia, and that will inhibit. There'll be I don't know why, low vitamin D levels. So again, they say that if you take higher doses weekly, we would recommend taking 4,000 units a day, and this is through the vitamin D. So tolerable limits. Okay, so you can look at that and say, again, age groups and safely can be given up to what point. That's it. So any questions?
Why is there such an epidemic of vitamin D deficiency in India with all its sunlight?
The reason we found out is that we have the fear of pigmentations and high screen. We're using a lot of sunscreens in our country. We are covering ourselves extensively. Our diets also have a lack. All of those have contributed, but really still, and there's a huge factor till now that I read, that melanin itself prevents darker skin's absorption of vitamin D. But more and more studies are coming that we might have higher parathyroid hormone levels in contrast to the Caucasian counterparts, which also prevents that. So those are the reasons why we found low vitamin D levels.
Where are the normal values derived from other eating?
Any clinical signs and symptoms of vitamin D deficiency? Or clinically?
That's what I showed the whole thing, from depression, that picture that I showed for the entire bodies, and that's why I said the effect is in every organ system, from skin, atopic dermatitis, if we start with the skin as a system, from CNS one, sorry Rekha, I'll just come back to your question, I just mentioned. So the CNS was depression, early Alzheimer's, memory losses.
Would it be a co-condition, or because only vitamin D deficiency cannot cause depression?
No, it has been associated to cause depression as a primary symptom.
No, most of the adults
because the dopamine receptor, the receptor mechanism have been found that vitamin D levels can affect on that level.
No, now what they said is 70% of the rural, 90% of the rural India are vitamin D deficient, but they can't be depressed, na?
No, but they are.
90% are depressed. Can't say that.
No, but it can exacerbate if you. It can be a cofactor into causing the depression.
Maybe a
No, but primary. What you read the studies are that primary depressions from dopamine receptor inactivation from low vitamin D levels have been found. So there are all those studies are unfortunately done in the Western society, and they are absolutely relating to vitamin D deficiency. And there used to be a high percentage of Swedish and Norwegian patients with depression, and they at that time found that the sunlight was low. But now they're finding those people have very low vitamin D levels, maybe from the sunlight being low. But it was not the sun as a factor; it was the vitamin D lowering in the body which caused depression. So there's huge studies out of those parts of the world which are saying that depression is caused by low vitamin D.
Injections versus oral medication.
Again, I said that injections are not to be used, even with a level of 2 or 0 or 3. Even with the patient having symptomatic, please use 60,000 units a week for 8 weeks and go down to 4,000.
If he has an absorption problem, then we can go for injectable.
Yes, if a person has a malabsorption, and even then, those D2 injections have to be. They're all D2 forms, and that conversion only lasts for about 3 days. So they last in your body for 4 days. So you have to keep giving it to them, not one dose and not giving for 3 months. So that's a totally different protocol.
So my question was, where are the normal values derived from? Is it that our normal values itself are much lower than that of a Caucasian?
No, what we have found out is what is a normal value of vitamin D. So there's a definition in Wikipedia for a normal level of vitamin D. A normal 25 hydroxylated D level is, let me just get it, it's a level which maintains the parathyroid hormone of your body at a particular level, and it is also controls the bone metabolism of a woman's some kind of index of a bone. So there's a definition for it is not derived from a population, it is derived from the level of that in your blood, yeah. So it's a very scientific, that's the normal value, right?
You said daily dosing. Why not just take 60,000 twice a month?
So yes, exactly. So I used to do that too, but lately, Dr. Rekha, that's coming out that those cause an instant surge of calcium absorption, which might cause some hypercalcemic symptoms in the body. then to give a gradual absorption of calcium and getting the whole body into a cycle where calcium is absorbed, deposited, and works on the parathyroid. So giving very high doses when the vitamin D levels are coming normal might backfire on us. So they're saying give it for 8 weeks and then give it daily.
Daily is 400, 600.
4,000. That's what I'm using.
4,000.
Yeah.
And is that likely? How long do you
Actually, that's so you do 4,000 for about 3 to 6 months. Check their levels. If they go above 70, then bring them to the daily endocrine dose, which is 600 to 1,000 for an adult. Yeah, maintenance. You will have to take vitamin D.
How many of you know your vitamin D levels? I'm curious.
I don't know.
So, yes,
Anybody? Come on, guys.
But I'll tell you, mine was 3. I took it, went up to 80. I didn't feel any difference.
I felt like a new
Huh?
person, Dr. Rekha.
Yeah.
Mine was 3, and I'm still only 35. So that's tried to be.
I went to 90, but I
but I
Now
felt
you have
like
to
a
check
$1
again.
million.
Anushya, fortified milk, all fortified with
There are
vitamin D.
a couple of studies, I just wanted to point out that calcium, there are a couple of studies, calcium given alone is actually harmful. There are more incidences of fractures. Calcium plus vitamin D is what, and because I see a lot of kids, especially kids, on
If you
calcium
look
all
at
the
the
time.
calcitonin mechanism, if you give high calcium, you're going to have leaching bones because the blood levels will rise, the calcitonin will be stimulated, and the bones will start losing. So you will actually have leaching from the bones. So high calcium levels, so giving calcium excessively might actually cause worsening of the bone without vitamin D.
Because in pediatrics, very common. I have patients come with calcium, which has totally inadequate vitamin D in it, and which is the standard practice. All kids are on it.
Do need vitamin D.
Yeah.
So what should you give? Like
You add calcium and vitamin
There's
D.
Shellcal
400.
HD, which has 800 units of vitamin D and 500 of calcium. Comes in India.
And then there's Just D also, which is 400 international units for 5 ml. It's just
That's
vitamin D.
without
She's asking calcium with vitamin D.
Oh,
for
calcium.
adults. Yeah.
Yeah, what should you do for kids, Shivasundar?
There's something called Just D that we have available.
That's vitamin D.
That's just vitamin
But
D.
calcium is vitamin D.
And then there is this there are several ones which have inadequate vitamin D in them, so you can kind of do half and half.
Shellcal syrup also is available. That's got calcium and vitamin D.
Meenakshi, you were wanting to say something about calcium?
It's vitamin D and calcium. That's it.
Okay, so we can start with the presentation.